our interdisciplinary team that looked at the geriatrics case. So you have seen her face before. Peggy and I worked together on the OU Health Science Center campus and interdisciplinary efforts and patient care. So I'm very pleased to have her come. She's an associate professor in the, is your Department of Nutritional Sciences? In the Allied Health College of Allied Health. Things I want you to listen for. One is that I want you to know what a dietitian does, primarily in the hospital. I want you to, today we're going to talk about dietary assessment. I want you to know that if a dietitian is consulted on your patient, what you should expect to get, what you should expect to hear out of them, and to know how they function within a team. So those are really important things to kind of have an ear out for today. And with that, I'm going to get my stuff and turn it over to you. And she'll tell you how to practice.
Thank you. Thanks for the invite. Glad to be here. Always happy to talk about one of my favorite subjects, and that would be the role of a registered dietitian. I'm going to focus today on the nutrition assessment and what all goes into that. Like Dr. Latassi said, if your patient has a nutrition consult ordered, you should expect us to do certain things or provide certain information so that we can provide the best possible care for the patient. So I get to practice out of this lovely little building here. I always love the chance to just let everybody know what you do. This is the College of Allied Health on the OU campus. We used to be the newest building on campus until they came along and built this fabulous new college of medicine. I want to take a little bit of liberty to explain to you just exactly what a registered dietitian does, and then also include some of the education and some of the background that we have to have in order to be a registered dietitian. 48% of our profession has a master's degree, and 4% of our profession has a PhD. We're currently, and I say currently because it's kind of a touchy subject right now, we're moving towards a master's level entry. Currently, a bachelor's level is the only entry level that you have to have in order to sit for a national registration exam. If 48% already have a master's degree, obviously a lot of us go on to educate ourselves further to get more of an education, and I'll talk about a few of the specialties that we also go on to get. So this whole master's level entry thing is a pretty hot topic right now. Some of us are for it, some of us are against it. But by 2024, and that sounds like a long time away, at that time you'll have to have a master's degree in order to sit for the national registration exam. We are pretty much dominated by female. We do have, and it's rising though, we do have 5% of our profession that is male though, and we keep looking for that to increase as we are accepting more and more males into the profession. So the age for the median age for a dietitian is 49 years old. 21% are less than the age of 35 years old. 35% are older than 55 years of age, so there's a pretty big spread there. After our education, we have to sit for a national registration exam, and that exam is given by CDR, or the Commission on Dietetic Registration. So that is the commission that is in charge of providing us with that RD credential. RD stands for Registered Dietitian. A couple of years ago, our academy, our national association, it's the Academy of Nutrition and Dietetics, decided that they wanted to incorporate that word nutrition into our title. The reason is, and we used to be the ADA, not the American Diabetes Association, but we used to be the American Dietetic Association. But we didn't feel that that really encompassed a lot of what we did. We didn't feel the word nutrition was in there. So they changed the name of the profession to the Academy of Nutrition and Dietetics, and they also added that in onto the credential. The thought process was that everyone can be a nutritionist, but not every nutritionist is a registered dietitian. The main difference is, does anyone know what a nutritionist is, what they do, what they can and cannot do, what they should and shouldn't do? Or, I mean, I'm called a nutritionist every day. I can take it. You can call me a nutritionist. But there is no educational requirement for a nutritionist. There is no national registration exam for a nutritionist. You guys can put a sign on your wall or your office or wherever you want to and call yourself a nutritionist. There's no governing body, there is no requirement, so anybody that wants to be can be a nutritionist. But not everybody can be a registered dietitian. So by adding that on, a lot of the younger folks, I graduated in RD, I'm going to retire in RD, I'm probably not going to become an RDN, but the newer ones coming through the program today will call themselves a registered dietitian nutritionist. So you're going to see those credentials, I'm sure. After we pass the national registration exam, 46 out of the 50 states require licensure. That licensure is required in the state of Oklahoma. It is the same licensure board or the same governing body that every licensed practitioner has to go through in the state of Oklahoma. So I am licensed through the Oklahoma Medical Board, and that allows me to practice as a dietitian. The licensure that we have is title only. Does anybody know what that means? I have to have it. I can't practice without it. But it gives me the permission to use that registered dietitian. It gives me permission to practice something called MNT, Medical Nutritional Therapy. You guys have any idea what that is? If I am a mother of a school-aged child and I want to tell them, please eat all your fruits and vegetables, am I allowed to do that? Are you allowed to do that? In your practice as a PA, can you say to somebody, please eat your fruits and vegetables? Sure, that's common nutrition, that's health, and it's good advice. It's just overall good advice. If I want to say to a patient that has diabetes, you need to control the number of carbs that you eat, you need to control your blood sugars, I'm going to work with you to give you a plan to do that. Can you guys do that?
Yes.
If I want to say you have stage 3 kidney disease, you really start to think about eating less protein, can you guys do that?
Yes.
That type of advice is medical nutritional therapy. Not everybody is licensed to do that in the state of Oklahoma. Are you guys licensed through the licensure board? Are you licensed to provide medical nutritional therapy? Don't know. I would think you guys would be able to give this type of advice, this type of information, but somebody that calls themselves a nutritionist and wants to write a menu plan and sell it to you that has no nutritional background, no degrees, no information like that, just wants to make a living, they cannot provide medical nutrition therapy. The line is drawn when you're trying to give advice for medical purposes. If a diet is going to have an influence on those kidneys, if a diet is going to have an influence over those blood sugars, that becomes medical nutritional therapy. So that LD allows me to provide MNT. We tried in the state of Oklahoma to increase or to readdress the type of licensure that we have. Titled insurance allows me to use registered dietitian, but it doesn't give me a scope of practice. So a scope of practice would be more inclusive. It would say I could order medications, or I can order lab values, or I can do these things within a scope of practice. We tried to do that. We went to the legislature. We tried to reword and tried to get a different type of licensure in the state of Oklahoma. People came out of the woodwork from every state in the country to try and deny us that right. The athletic trainers, the people that came, speech language pathology, I mean, it was unbelievable, the people that said, no, you don't have that right. You can't take that right away from us. We want to be able to do that too. There's currently a case in the state of Florida that a person who calls themselves a nutritionist is claiming free speech, that we're taking away free speech rights. And they want to be able to write menus, they want to be able to do this wellness coaching, they want to be able to provide all this and make a living. At the current time, they haven't won. It's a case worth studying though, it's a case worth following, because according to this individual, we're taking away her free speech, we're taking away her rights. So stay tuned. If I find out more information, I'll try and keep you updated. So besides the RD behind my name, I also have the LD, and one other title that is on my particular credentials is FAND. That stands for a Fellow of the Academy of Nutrition and Dietetics. So you're going to see some of these initials. You're also going to see several other initials because the Commission on Dietetic Registration also has a few other board certifications. So these come specifically from the credentialing body. There's one for geriatrics, there's one for obesity, weight management, oncology, pediatrics, renals, and sports. So these are additional acronyms that you could see after the end of somebody's credentials as it on their signature. There's a brand new credential. The first time it started was last year. It is an advanced practice credential. As of the last time I checked, only 37 people in the whole United States have taken that test at this time. So again, we need to do a little bit more marketing to get that credential out there. Are there any other initials or abbreviations or titles that you've seen people use that you're not quite sure what they are? No? There's several other acronyms that we can take an exam for or try to achieve as we continue to advance our knowledge. The CNSC stands for Certified Nutrition Support Clinician. This used to be used for a CNSD, a CNSS, RN, a CNS, what was the doctor? CNS MD? I don't know. So nutrition support is feeding somebody through a vein or through a nose. And that association, it's called the American Society for Parenteral or Enteral Nutrition, decided that, hey, we're interdisciplinary, we're all trying to help the patient when it comes to nutrition support. So they changed the acronym to CNSC. So whether the C is, the clinician is a doctor, a nurse, a pharmacist, a registered dietitian, they're all able to use this certification because they've passed another specialty exam. Dr. Latassi, you're still a CDE?
Yes.
So a CDE is a certified diabetes educator. That can be a nurse, that can be a pharmacist, that can be a dietitian, that can be a doctor as well. So that is another exam. You're required to have so many hours worth of practice in that particular area before you take the exam. And then you also have to keep up your education so many hours in order to recertify or to keep those credentials. Is it every 5 years?
Yes.
So the CNSC, there's no requirement for education, but it also has to be repeated every 5 years as well. Then the last one is CHES, that's a Certified Health Educator Specialist. So you might be seeing that some of those credentials from people that are signing notes or making recommendations for you. As far as where we work, we're about 50% in the hospital and 50% out. So clinical is the area where most dietitians start. They may go on to other things after that. But if you're in a hospital for at least a year after you graduate, you've got a pretty good basis or a pretty good start before you go on to other different areas. If you want to go into renal, if you'd like to work in a dialysis center, you have to have that first year's worth of experience before they'll hire you. So clinical is kind of where we get our feet wet. 50% of us stay there, but several of us go on to other different areas. 8% in long-term care, another 10% in community. Community might be something like a WIC place, a health department. We've got HIV clinics, we've got cystic fibrosis clinics. It would be some type of community type arrangement where you work. Food management, I'm surprised that's not the lowest one. Not always our favorite position that we want to hold, but it is the highest paying one. In a food management position, you hire, you fire, you're in charge of the budget. You have to stock it, you have to discipline, you have to do all kinds of things. Things that you might not have to do in a clinical situation unless maybe you were a clinical nutrition manager. But the food management dietitians usually bring in the higher salaries. So who knew that Frito-Lay has a dietitian, that Coca-Cola has a dietitian, that Campbell's Soup has a dietitian, that Hershey has a dietitian? There's a whole lot of us in the business world working with them to try and improve the products or reduce sodium in a product or take out trans fat in a product. So a lot of dietitians are in the business world. The rest, people like me, go into education or research. I've done the research track for a little while. I did that. I did a clinical trial for a while. I was a, what did they call me? A research coordinator, I guess, for a couple studies. I did clinical for a while. I did long-term acute care hospitals where patients stay for a longer period of time, and then finally after some of that I moved into the educational world. Been there since. All right, so let's start to talk about the process of the nutrition assessment. You guys are probably pretty familiar now. They've been drilled on doing a history and physical, and they've been there, they've done that, they've read about it, they've experienced that. That's kind of the backbone of the medical world, and it's been done for a very long time. You can go to any chart, you can find a history and physical, they pretty much go bam, 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 down all the different organ systems, you know, the flow. It's pretty much a standard type operation. Nutrition never really had that formal of a process. We're pretty good at what we do, but I did it this way, another one did it that way. We might all get to the same point, but never had a formalized process. That changed though in 2004 when we came up with something called the nutrition care process. The nutrition care process involves 4 steps: doing an assessment, coming up with a diagnosis, coming up with a nutrition intervention, and then monitoring and evaluating that whole process. So here's the 4 steps, 1, 2, 3, 4. If you'll notice, for the nutrition assessment, I highlighted the A. For nutrition diagnosis, the D. I and the M and E. That, if you put that acronym together, that says ADIME. So now, the type of note that we use, you guys are probably learning to do self notes. We can, but we use a type of a process called ADIME, which stands for each one of these different abbreviations. All right, let's start with that first step. The first step is the nutrition assessment. This is the definition. It's a systematic method of obtaining, verifying, and interpreting data needed to identify nutrition, and I should probably highlight nutrition on this slide, nutrition-related problems, their causes, and their significance. We're not trying to take anybody's job away from them. We're not identifying hypertension. We're not identifying cardiovascular disease. We're not identifying renal disease. We're not identifying or diagnosing cancer. What we're working is to find something that we can put in a problem, we can form an intervention, and we can fix it and come out with a good outcome. So the diagnosis that we're going to do is going to be nutrition related, and I'll give you several examples. So where you guys have this process down pretty pat, we're kind of new at this. We're just getting diagnostic skills and stuff down pat. And we're beginning by doing something that we've done for a very long time, and that's collecting data. So the assessment begins with collecting of data. It might be from a medical record. It might be from the individual themselves. The whole nutrition care process isn't designed to just be clinical in nature, though. This is something that literally you can expand out or provide in a community situation as well. So it might be from historical records or other type of information that you're working with. Once we collect the information, all of these different pieces to the puzzle, then we have to use critical thinking to determine what's really important. What piece here is valuable to determining what the problem is, or what piece needs my attention the very most or immediately, or the thing I have to fix first. So the nutrition assessment is performed by the registered dietitian. That is a little bit different than a screening process. JCAHO, the Joint Commission on the Joint Commission for Accreditation of Healthcare Facilities or whatever, requires that every patient that is admitted have a screen within 24 hours. That screen has nutrition information, it has personal information, it has jewelry information, it has several medication information. That first screen in the first 24 hours is usually done by the nursing staff. Depending on how patients score on the 2 or 3 questions that they ask about nutrition, they may need to be referred to the registered dietitian. If they're referred to the registered dietitian, then we're going to start this whole 4-step nutrition care process. But if they're just there for elective surgery, if they're there for, a test or a procedure and they have to stay overnight or whatever, there's a chance that they're not even going to be triggered to need the services required by the registered dietitian. There's several different tools that we use for the screening or for the assessment process. The one I have pictured up here is something called a subjective global assessment. If you look here, we're looking for some pieces of information about their weight history. We're looking at some dietary intake, different pieces of information to determine whether or not some type of nutrition intervention is really needed. So this is a tool you're probably going to find in a clinical setting. There are several other tools, though, that might be used in the community situation. There's something called a determined checklist. It's a 2-page document used a lot in community experiences or community environments where you just ask patients, do you eat alone? Do you take multiple medications? What you're trying to do is to come up with a score to figure out whether or not these individuals would also need the help of a registered dietitian. This is the MNA, Mini Nutritional Assessment. Used a lot in the elderly. This is something that we'd probably use in a clinical setting. And there finally, I have a picture of Determine Your Nutritional Health. That's the checklist. Used a lot in health fairs, used a lot maybe at nutrition centers where people can come have a hot meal every day. So various tools are used to help us determine what the needs of the registered dietitian really are. Questions? So far so good? Go too fast? Cool. All right. So the actual assessment process itself has 5 different domains, or 5 different areas where we're going to focus our attention, where we're going to collect that data, where we're going to look to see what's important, what's not, and to help us determine what the actual problem is so that we can complete or figure out what an intervention needs to be as well. So the nutrition assessment is focused around client history, biochemical test and procedures, anthropometrics, NFPF stands for nutrition-focused physical findings, which we'll talk about, and also the food and nutrient-related history. All of these topics or all of these areas are what we ask the patient about. Make sense? Let's start with the client history. You've seen probably a lot of this information before. It's your age, name, rank, serial number, 56-year-old female, positive for tobacco or negative for alcohol. But we ask questions about their housing, whether or not they can afford to buy food. It's required through the Joint Commission. We have to ask about cultural preferences. We have to honor those. So if nursing hasn't already addressed that, we need to go in there and ask them if there's any cultural do's or don'ts. They're entitled to that, whether in the hospital. And then also the ability to, whether or not they can even afford food, they live in a food desert. Those are the type of personal questions we're going to ask. We are interested in their food or in their medication history. There's food medication interactions, so we need to know about their prescriptions. We need to know whether or not they're taking them. We need to know their over-the-counter medications. Why do we care about complementary alternative medications? Any idea? They have food medication interactions, absolutely. St. John's wort really interferes with HIV medications. And a lot of times that question isn't asked. What type of complementary alternative medications do you take? Or if a doctor has asked them, tell me about your medications, they don't really think a vitamin is a medication. They don't really think a calcium supplement is worth mentioning. They don't really think it's important to, ask for that vitamin D or some of those things. So we're in there and we're wanting to know each and every one, whether it's complementary alternative or whether it is over the counter or not, what exactly they are taking. And then the past medical history, obviously we need to know how many times they've been bypassed. Or during that bypass experience, did you get any type of nutrition education? Also, family medical history, whether or not there's some hereditary things going on, what have you. We're also obviously very interested in lab values, just like you folks are. Which lab value that you noticed, or that I've got up there on the screen, do you think we probably consider least important?
Hemoglobin?
Huh?
Hematocrit?
I heard hematocrit.
Hemoglobin?
Hemoglobin. Vitamin D.
Albumin.
Who said albumin? You win. You're the winner. Why do you think that that is probably the least? It's not the least important, but why do you think I would consider that less than, why should I care what the potassium is? Why should, I really do care about the hemoglobin and hematocrit because I'm looking for anemia or something that could be affecting the red blood cells. Why did you say albumin?
I heard the question wrong. I thought you said what's most important.
Oh.
So obviously my thinking's backwards. I was thinking like that indicates like how much you're actually intaking like protein wise, which is base, I guess, for energy. I don't know why it's the least important.
Would other things be changing before that actually change?
Depends.
So it'd be like a later.
Not very
Because it
specific.
suggests a pathology or anything like that, or affects disease processes as much as the others.
All good thoughts. The thought processes are there.
Does it change your nutrient intake?
Does it change it? Sure, it can.
Oh, no, that's what the paper you have.
So this is article number 1. This is the one-pager. So why we are still monitoring albumin. Historically, albumin has been the be-all, the everything when it comes to nutritional status. Nothing could be further from the truth. And I'll explain that a little bit more. I'll go into much more detail. But glucose, obviously, but medications can affect glucose. Critical care can also affect glucose. So those are things we have to look at and consider. Vitamin D can affect calcium absorption. So you have no vitamin D, you're not going to absorb the calcium. So why are we going to recommend a calcium supplement if their vitamin D level is low? The electrolytes, the sodium, potassium, everybody's interested in those in care. So lipids, obviously, good, bad, high, low, those things all are very, very important. They always order albumin, well, pretty much. And I don't want to say up until recently, because what does the article say? We're still measuring it, or we're still using it as a nutritional marker, even though the evidence for the last 10, 12, 15 years or so have said, no, let's not do that. So let's keep that thought. We'll talk about that more in just a second. So in the domain for biomedical tests and procedures, we're obviously interested in different lab values. We're also interested in how safe that patient is to eat. If they've had a stroke, they may have had damage to the muscles that allow them to swallow safely. So I don't want to feed somebody if there's a safety issue. We want to look at that biopsy report. We want to know what's going on, whether or not they're scheduled for surgeries. All of these pieces of information, or all of this data that we're collecting, is going to help us determine what the problem is and what we need to do. The next domain is anthropometrics. Anthropometrics is anything that you can measure, or just about anything that you can calculate. So we look at height, we look at weight, we look at that BMI. Not going to go into whether or not BMI is a good indicator. It is one of many. So it's one measure that you can use, and it is recommended by the CDC. Biggest thing up there that I'm probably going to be interested in is a percent weight change. So yes, I can calculate what a person's ideal body weight is, but I may have had a guy that is 6'3", all of 135 pounds, soaking wet. He never is going to weigh his ideal body weight. He's skinnier than you can imagine, but this is the way he's been his whole life. I'm not going to change, I'm not going to make him move to an ideal body weight just because the chart says this is an ideal body weight. That's his usual weight. That's what he's always weighed. That's what he's going to weigh tomorrow and months from now. So the biggest thing we're really looking for is the percent of a person's usual body weight. Even if they're obese and they've had a 20 or 30 pound weight loss unintentionally, that's huge. That's big. We need to address that. We need to know why. So the most important figure off of anything there would be a percent of a person's usual body weight. If there's unintentional weight loss going on, we have a problem. If they're below ideal body weight, always have been, always will be, I'm not concerned. But if they're losing weight unintentionally, then it's going to send up red flags. The NHANES, the National Health Nurses Education Survey and Nurses Education Survey, has a fabulous YouTube series on anthropometrics and the exact procedures that you can use to get them correctly. Anthropometrics aren't very valuable. I don't want to say that we shouldn't get them, but different clinicians are going to have different techniques. Some are going to say weigh with your shoes on, others are going to say weigh with your shoes off. Some of them are going to do a waist to hip ratio, and there are the tape measures all over the place. So if you want to find the standard for doing a hip to waist ratio, or a standard for doing a height or anything like that, those YouTube videos are an excellent source to go. What we're really looking for here is some type of a trend. It's going up, it's going down, it's intentional, it's unintentional. Those are the kind of things that we're really looking for to try and establish. A one-time figure for a weight on a once in a occasion, or the only time they've ever been anywhere, really doesn't tell you anything, whether it's good or bad. But if we have history, if we have background, that's why electronic medical records are so beneficial now. We can see trends, they have all kinds of graphs. It's much easier to trend or look at this type of information. Anybody know what this is a picture of? surprises. Old age,
Excellent.
eczema. I use this to introduce the next domain that we're focused on now big time, and that's nutrition-focused physical findings. This is a picture of pellagra. Pellagra is a niacin deficiency. So what we're trained to do, what you should expect your registered dietitian to do, is to perform a nutrition-focused physical exam. Here's a couple documents that I'll send around showing you some pictures, showing some of, this is my favorite, this is my least favorite. Here's another book that is written by a dietitian on nutrition-focused physical assessment. Doctors are busy, nurses are busy. A lot of people aren't looking at that, that scrape you have on your hand, or, I don't know where I go, aren't looking, sorry about that, aren't looking at the cracks on the side of the mouth, or aren't looking at, what are some other, that rash. Maybe somebody doesn't think that rash means very much, so they don't even bother to point it out to the doctor. A nutrition-focused physical exam is meant to point out some macronutrient deficiencies. The biggest ones would be fat or protein, muscle loss, or fat stores that are diminishing because of an illness, or point out some macronutrient or micronutrient deficiencies. Iron, obviously, or folate can both be related to anemia. Folate can be related to neural tube defects. B12 also could be anemia, could be other things. Niacin is pellagra. There's one more below there that you can't see on the screen. Can you see it on this screen?
Zinc.
Oh, you can see it on your computer. Zinc, a very important nutrient deficiency. Deficiency of zinc could lead to a lot of rashes. So these are the things we are trained to go out and look for. This is nutrition. We know a deficiency when we see one. So when you ask for that nutrition consult, you should be expecting them to do that. Here's some other nutrition-focused physical exam findings that we're looking for. The muscle wasting, the fat wasting. We call it the head to toe. We can start at the head. We can look at the hair, the nails, the skin. We look at hydration. We can do a little simple test to look at their skin tumor, know how well they're hydrated. The physical appearance. All of this information is in one of the handouts. The second one, I think, depending on how you, if you did nothing, this is a handout from a DPG or a support group that we have. If you did nothing but take page 9 and 10, if this is the only thing you kept out of that article, you'd see all these nutrient deficiencies that happen on a daily basis. So this is part of these, what I call the support line article. Right here. Yeah. And I printed this off for you just so you could keep this one pager here then to have references about nutrient deficiencies when it comes to nails, hair, skin. These are the things that people don't notice every day. These are the things that we're trained to do, and you should expect us to do it because they have to do with nutrition. We learn the same techniques that you probably learned. Inspection is the one that we use most often. We're going to use auscultation to listen for vowel sounds. The ones we're probably going to use less often are the percussion or the palpation. So the last domain that I want to talk about is the food and nutrient related history. This is the questions that we ask that nobody else bothers to ask. Like, what did you have for breakfast? What did you have for lunch? What did you have for dinner? So we can do nutrition analysis, or we can get an idea of what their diet is really like. We can ask questions about food insecurities. We can ask them about that physical activity that you were learning about earlier in the day. We're also going to do something to calculate their needs on what we think they should be consuming. We have to have what they're actually taking in compared to what they should be taking in to know whether or not we have more or less. So we do need to calculate. We need to know if they've had any prior nutrition education. Do they follow any particular diet? Were they told to follow a diet and they don't follow it? All of this is information that comes under the nutrition, food and nutrition related history. We can find some of this information in the medical record. We can look at the nursing graphic. We can ask the patient to do a 24-hour recall. Food frequencies are used quite often in research. Weight Watchers is probably the best organization that asks people to keep a food diary. You really don't want to eat that donut if you gotta write it down, so that can be pretty preventative. Hospitals are notorious for ordering something called a calorie count. And in research, they're also doing a lot of plate weight studies where you weigh food and plates before and after to know how much they actually consumed. Probably one of the most exciting things now is there's an app for that. So people are excited about keeping their information in MyFitnessPal and all of these other type of places to keep and record a lot of that information. This is an example of how we would document in, say, a hospital setting, usually 25%, 50%, but this is a guideline to help nursing document that. We need to look at that information to know whether or not good, bad, and different. Here's a 24-hour recall. This looks like a food frequency that somebody may use in research or with the patient themselves. And then other things that might come up, things that we might ask questions about is, can they bathe? Can they cook? A lot of times these are called activities of daily living. So we need to know whether or not they can feed themselves. Maybe they're there with a broken right hand and that's the hand that they use to feed. Another thing that is becoming more and more popular is called hand grip strength. So this is a hand grip dynamometer, and this is used, I'm going to talk about malnutrition a little bit more here in just a second. This is one of the criteria that is used to determine malnutrition. So I've had surgery on this hand. I wouldn't expect this one to be very good. I need to turn it on. But you ask the patients to squeeze this and then a number appears here. So this is a tool you can play with. Another way to do the exact same thing is, hi, how are you? That's a pretty strong hand grip. Or I can go up to them and say, how you doing? I'm going to ask you a few questions. I just did a nutrition-focused physical exam because I found that the shoulder was pretty healthy as compared to all skin and bones. So we'll talk a little bit more about the hand dynamometer here in just a second. I think we're coming to a pretty good spot here, maybe to take a break. So in summary then, as far as the nutrition assessment, the screening leads to a full-blown nutrition assessment. Nutrition assessment is the first step. We still have several other steps to talk about. So we use certain domains to collect all this information. We need to analyze this information. Then we have to go on to the next step, which will be to determine a nutrition problem. So, too early to take a break? Let's take 5 or 10.